An international AIDS conference in the US is calling for an AIDS-free generation. How is that possible when a drug-resistant HIV is on the rise in parts of sub-Saharan Africa and millions of sufferers are still dying in developing nations? We ask, are countries that can afford to deal with this epidemic doing enough for the poor? And how much longer will we be fighting HIV/AIDS? This is Inside Story. Hello, a very warm welcome to the programme. I'm Jane Dutton. Turning the tide together. That's the motto of the International AIDS Conference being held in Washington, D.C. Perhaps a fitting venue given the high HIV rates in the American capital, where numbers are comparable to some parts of sub-Saharan Africa. The conference kicked off on Sunday evening. It's aimed to bring together more than 20,000 people to discuss how to improve the lives of those living with HIV and AIDS. Doctors and patients of HIV/AIDS are urging the international community not to forget about the disease, saying research funding must continue. The virus was first identified in 1981 when most of its victims were gay men and injecting drug users in the US. It's since moved a long way on from that. Nearly 30 million people around the world have now died. And right now, more than 34 million are thought to be living with HIV, the virus that causes AIDS. There's no cure, but antiretroviral treatment is showing promising results. And this week, the US approved a drug that could reduce the risk of infection by up to 75%. And very recently, experts writing in Lancet's medical journal found that drug-resistant HIV has been increasing in parts of sub-Saharan Africa over the past 10 years. They said resistance could build up if people fail to stick to drug regimens and because monitoring could be poor. So why is the West winning the battle against AIDS when the poor in developing countries are dying in the millions? To answer this question, we're joined by our guests. In Madrid, Mariano Esteban, he's a head researcher at the National Biotech Centre. In London, Jason Warrener, clinical director at Terence Higgins Trust. And in Johannesburg, we have Edward Cameron, Justice of South African Constitutional Court. Welcome to all of you, gentlemen. Dr. Esteban, let me start with you. There's a positive vibe, a positive spin coming out of the conference in the US. Secretary of State Hillary Clinton predicting an AIDS-free generation, and certainly there's been talk that a cure for AIDS is imminent. Are you as upbeat?
Well, I think that there has been a tremendous progress being made in the last 30 years, and I think mostly in the last 10 years, I would say. So this has allowed us to know more precisely how the virus infects the body and how our defenses are capable to fight back. And that has been particularly enhanced by the antiretroviral therapy, by which we have been able to suppress completely or up to undetectable levels the virus infection in persons infected. So this has been a major achievement which allowed Secretary of State Hillary Clinton to claim that the eradication of HIV could be close. I wouldn't say imminent, but I think that we are sort of getting close.
Even without a vaccine?
Well, we need a vaccine because still to completely eliminate the virus from the body, from lymph nodes and from the sites where the virus hides and remains to low levels, but significantly to start the new infection. Once the drug therapy is withdrawn, then to avoid that and to really get rid of the virus, we need a vaccine. And this is something the WHO has made a clear message, that a vaccine is needed to eradicate HIV.
Mr. Warren, I should imagine that this news excites you somewhat.
Yes, it does. I mean, every day we get to move forward with HIV, with all the research and all the drugs that are coming available. What we have to remember is getting people tested and early diagnosed for HIV and getting them on treatment. When somebody's on treatment, this dramatically reduces the risk of them transmitting the virus to other people. In relation to a virus and looking at a vaccine, we've done a lot of research around the vaccines, and we're still a number of years away from the vaccine. But the key thing is pulling all the research together to look at how we move forward with the vaccine that can be rolled out across all of the UK and plus all of the world. But within that, making sure that it can cover off the different strains of HIV.
Justice Cameron, it seems quite incredible, doesn't it, to be talking about a cure when still millions of people around the world, particularly in developing nations, are still dying.
And still being infected, that's the trouble. In fact, since 1984, there was a famous press conference where the US Health Secretary, I think it was Margaret Hechter at the time, said we are within 5 or 10 years of finding a vaccine. That was 27, 28 years ago. So I'm skeptical about talk of vaccines and cure. If they happen, I'll be delighted. But as an African who myself has been living with this virus for 27 years now, on treatment for very nearly 15 of those years, I think that we need to have a much broader based strategy. We mustn't over-medicalize this problem. The medical giants, the medical researchers, medical science have given us what I'm alive and in the studio this afternoon because of, which is effective suppression of the virus. I've been on antiretroviral treatment, as I've said, for very nearly 15 years. But in South Africa, for example, we've got the world's biggest publicly provided treatment program. We've got 1.7 million South Africans on publicly provided treatment, which is a terrific success for President Zuma's government, in particular for Health Minister Aaron Motsoaledi, who's been a real crackerjack about the epidemic. But at the same time, as I'm sitting here, 1,000 new infections are occurring in my country every day. Around about 300,000 people, slightly over 300,000 people are being infected every year. So we're still losing that battle. We have to have a strategy that includes medical science, which is terrific, which includes the array of weapons that medical science has already given to us, which is effective combination therapy, highly active antiretroviral therapy. But we also still need to get to the people who are exposing themselves to the virus unnecessarily, and we need to get, as I think our colleague in Madrid said, we need to test people. We need to test people effectively. We can get to everyone who is living with the virus now, as I think Mr. Warren has said in London as well. We would be able to stop the active virus in all people carrying the virus, because that's what successful antiretroviral therapy does.
Okay, let me put that to Dr. Esteban.
New infections.
Justice Cameron was raising the fact there that people need to be tested to put a stop to this. I mean, across sub-Saharan Africa, more than 26 million people are living with the virus. We've got 2.3 million deaths a year from AIDS-related illnesses. How do you test those people?
Well, I think that we have now new techniques by which we can rapidly assign mutations that may have occurred within the virus circulating in a community, in different individuals. So we can develop the simple assays by which we can assign what the mutations are in those individuals and how they correlate with the antiviral therapy that they are using. So this is generally a general thing that a virus develops resistance to any drug. So, and although we are using now 3 different drugs to really suppress to near completion the virus in the body, so still the virus may manage to escape, and these viruses that develop resistance will dominate in the virus population within an individual.
I mean, is there a divide, excuse me, jumping in here, is there a divide in HIV AIDS research in rich countries compared to poor countries?
Well, well, the question is that in the developed countries, in the rich countries, as you pointed out, so each individual is being followed up very closely. And and then it's the infection is well controlled, and basically you keep to undetectable levels the HIV infection, and that because it's been closely followed at the hospital, and that makes a great advantage. The problem is in Africa to follow each individual is quite difficult due to just economical situation and the logistics. So that's something we have to develop a quick way to assess whether the combined therapy should be changed and what will be the optimal. And
okay, let me put that to Mr. Warner. I mean, very few people are dying in the West, are dying in wealthy countries, and that's not the case in developing countries. Why do you think there's such a disparity? I know that you work in the UK and you worked in South Africa as well.
I think the key issues what we have to look at is access to healthcare services. If you look at the developed world, UK, America, you've got access to healthcare services, people can get tested and get onto treatment programs. When you're considering developing countries, it's access to healthcare services. We have people who walk for many hours to access a basic clinic when a doctor visits there, which could be once a week. But within that, it's also looking at some of the fundamentals. Have people got access to food and water? And we have to consider all of this when you're looking at programmes, and especially around HIV in relation to the long-term effects of HIV on the body, adding nutrition and malnutrition into that, the concerns around other health problems such as malaria. If you bring all those factors together, they can have a big impact on a person's life. If you look in the UK, we've got people get tested. If they're diagnosed with HIV, they've got access to support systems and treatment, and they do not have to pay for the care. So it's looking at this wider issues around the availability of healthcare, but also how people can access it and not have to pay for it.
Justice Cameron, you were saying that you've been infected for 27 years, that you've been on antiretrovirals for 15 years. What sort of impact has this had on your life? And do you think that you've been relatively lucky, as I'm sure you have been, because you've had the money to afford it?
Well, I'm extremely lucky, Joan, because I'm here this afternoon and I feel a sense of joy every day simply because of that. And I was very lucky because I fell ill just after the drugs started becoming available. And the big fight in Africa, as both my co-guests have indicated, has been to make drug access available to Africans with HIV on the same scale and with the same relative accessibility and ease as it is now available in Northern Europe, Western Europe and North America. So I feel extremely lucky, Jane. And since the denialist nightmare under President Mbeki, we've moved towards an enormously effective national AIDS policy. But the primary problem is still one of stigma. We haven't completely got over stigma yet. We've got what the epidemiologists call a mature epidemic in South Africa. It's a dreadful concept. It means that every South African, those sitting in the studio with me, those in the building with me, those around me in the city of Johannesburg, every single person, black and white, middle class, working class, rural, poor, rich, everyone knows someone who's died of AIDS. We all do. So it's a mature epidemic, and that in itself does something for stigma. When you've got a sister or cousin or an uncle or a lover who's died of AIDS, your attitude towards the stigma changes. You become less condemnatory. But we're still battling with stigma. It goes back to the question that I think Mr. Warren or the doctor raised of how do we get to the 20 or 25 million Africans who are carrying the virus, because only a tiny fraction of them actually know that they've got the virus. And that's a social problem. It's not a scientific problem. We've got the scientific instruments, the quick tests, the rapid assays, the longer term tests, the PCR tests. We know how to test for the virus very effectively. The question is to bring people who are at risk into testing, into treatment, and also to get people who are at risk of HIV infection to change their behavior into health-seeking ways.
Well, one of the speakers at the conference in Washington, D.C. was the singer Elton John, and his message was pretty clear on the subject of stigma.
The AIDS epidemic is fueled by stigma, by hate, by misinformation, by ignorance, by indifference. There's so much talk now about the end of AIDS, and rightly so. We can end AIDS.
Dr. Esteban, what role does stigma play in your research?
Well, because I think that we, been living with the HIV/AIDS pandemic for a long time, and the society here in Europe, and particularly also in Spain, that the people are aware on the disease. Now we are concerned about the young people, that they think that there is a treatment and they don't have to worry about it. And we are just trying to tell the people that this AIDS can be, anyone can be infected. They have to take measures, and the disease is around us, and the virus, and so but still the young people, they don't take it seriously.
And do they not take it seriously because of people, excuse me, like Justice Cameron, who looks the epitome of good health? Do they think, oh well, you know, if I get AIDS or if I sleep, you know, have unprotected sex, it's not really going to affect me? Is that a problem?
Well, as I say, that it's something that the health authorities here in Spain are just launching the message that people have to be aware, that they have to take precautions, and that the virus, anyone can be infected, and still Spain has the larger number of new infections here in Europe. So still, I think it's a serious disease, a highly serious disease that they have to be aware. But now the society, people infected with HIV are having an ordinary life, most of the people, and it's like a disease that is being considered as something that can be controlled and people can live with it in normal life, and so that every single individual, basically, that is known to have HIV infection is being followed up.
Okay, Dr. Esteban, I'm going to ask you something as well, because I'm afraid we're going to run out of time before I even ask you this. There's another problem, isn't there? There's the fact that resistance to antiretroviral drugs is increasing, particularly in sub-Saharan Africa. What's that all about?
Well, I mean, the big question is that to avoid resistance of the virus, you have to maintain the treatment continuously, on continuous basis, because we know quite well that once the treatment is interrupted, the virus comes up very quickly. And that is why it's critical that the treatment has to be maintained for life. And that's something that people have to be aware that they cannot interrupt the treatment. And I think this is very well established.
Justice Cameron, is that something that's difficult when you start feeling better taking the treatment? I mean, how does it feel to have this deadly virus in you?
Well, that brings me back to the previous point I want to get back to for a moment, Jane, because it's a double message we've got to get across. We've got to get the message across that the doctor says that this is a manageable infection, that your life prospects are almost the same as someone without HIV. I'm nearly 60 now. I can look forward to more or less the same age as a 59-year-old healthy, fit, well medically cared for man in my position without HIV. But at the same time, we've got to get the message out that you've just put in your question to me, which is that you don't want HIV. Just don't get it. It's inconvenient, it's unpleasant, it brings with it stigma. You've got to take those tablets every day, you've got to have your viral load and CD4 count tested twice a year. Don't get it. But the health message is not dissimilar to that with smoking or with insulin-dependent diabetes, where people have lifestyle factors which predispose them to disease. Even though people know that smoking kills, upwards of, I think, 18% of Americans still smoke. So people still engage in risk behaviors that expose them to the HIV virus, and we've got to get a more effective message out there that even though it's a thoroughly medically manageable disease, you still have to take precautions against it. And if I can just get back to the personal part that you did ask me in the question, I've been taking my tablets now for almost 15 years, and it becomes a part of your lifestyle. I think most people in Africa, rich or poor, highly educated or relatively less educated, understand the need to sustain their antiretroviral therapy thoroughly. There's been tremendous treatment literacy education in South Africa and in the rest of Africa, led by organizations like the Treatment Action Campaign. We've had a very successful, that's the organization that took on President Mbeki's AIDS denialism, took him to court, got the court order against him, and they're also the ones who've led in treatment literacy. So it's very well understood. The problem is just getting people to translate it into action.
I mean, that's so correct, isn't it? I mean, Mr. Warren, I'm going to read something to you from the States. 1 in 5 Americans with HIV don't even know that they have it. That means more than 200,000 people can unwittingly spread the disease. I should imagine that's a problem in the UK as well.
Yes, it is. In the UK, we know that we've got 100,000 people who are living with HIV, but 25% of those people have never tested and do not know they've got HIV. This is where we need campaigns around public awareness. So if people think they've been at risk of HIV, they'll go and get tested, but also targeted campaigns and taking services to hard to reach groups, such as some members of our African community, men who have sex with men, gay men, and sex workers. So it's actually taking services out of traditional healthcare settings into settings where people feel they can access them, get tested and feel the confidentiality is there. Part of the problem we've got is around stigma, and that can be stigma around fear of having a HIV test, or if people find out you've had a test, they immediately pass a judgment on you, whereas actually going for a test is responsible and it's actually taking positive action. We're doing a lot of work around stigma at the moment, and in many ways it feels sometimes we're back in the 1980s with the prejudice, lack of knowledge, fear around HIV. So it's moving people forward and getting a realistic view of HIV, and some of the key concerns we've got is making it clear to people how you can get HIV but how you can't get it. And we still have people who think you can get HIV through touch, through sharing food, what somebody with HIV is prepared. So we've got to address all of those issues, but the key thing is actually reducing the number of people living with HIV who don't know they've got the virus, and the vast majority of those people who are the ones who are infecting other people, they're having sex without condoms, and they're just unaware they've got the virus, and it's not deliberately infecting people, it's just happening. Okay,
Justice Cameron, taking all that into account, do you foresee a time when we'll be looking back, maybe not in our lifetime, and saying, oh, remember AIDS, remember, it's the equivalent of bubonic plague, and thank goodness it's no longer here?
I hope so, but I think it's going to take a long time. I think we're looking probably to the next generation. In the absence of that medical magic bullet that we started talking about at the beginning of the program, we're probably looking to the rest of our generation and well into the next generation before we're going to live without HIV. So the issues in Africa, where 2/3 of the world's HIV positive and AIDS sick population are still massive and still require tremendous commitment of leadership against stigma, in favour of prevention and in favour of testing and treatment.
And we've got to get people like Dr. Esteban working on that cure. Thanks very much to our guests for joining us on Inside Story. In Madrid, Mariano Esteban. In London, Jason Warrener. And Johannesburg, Edwin Cameron. Thank you always for joining us on this edition of Inside Story. If you want to send us your feedback, just email your thoughts to us at insidestory@aljazeera.net. For all of us here at Inside Story, I'm Jane Dutton. Goodbye for now.